this. And the answer is not real well. So there's a giant chasm between the theory or the law of informed consent and the practice of informed consent. So we have in theory these appellate opinions like Canterbury and other appellate opinions talking about the importance of patient self-determination and patient autonomy. But in practice, things are different. In practice, things don't work at all like the way these appellate opinions are describing the doctrine. So let me just start with this recent obituary from the New York Times. This is the obituary of Jerry Canterbury, and we read the Canterbury case. And why did we read it? Well, as the New York Times tells us, this was a case decided by the D.C. Circuit back in 1972. So most of us are not in Washington, D.C. Why do we care about this really old case? Well, because it is the landmark ruling in informed consent, right? That, as the New York Times says, that fundamentally transformed how doctors deal with patients. So here, we read about Jerry, 19-year-old with back pain, ultimately tries to address that by getting a laminectomy. He does get the laminectomy, type of back surgery, and we will recall from the prior week, that laminectomies entail a 1% risk of paralysis, even when non-negligently performed, which this one arguably was. And of course, Jerry's doctor did not disclose that 1% risk of paralysis to Jerry. Now, we read that, and what we read was the D.C. Circuit opinion, and that court imposed a new legal duty on physicians. Now, after Canterbury, physicians have to obtain not just the patient's bare consent, but also the patient's informed consent. We know that what the appellate court held, as a matter of law, is that physicians have a duty to disclose all the risks that a reasonable patient would find important. Because they articulated the standard, they articulated the rule, but they had to remand it back to have the finder of fact apply that rule to the facts in the case. So that happened. The case was remanded back to the trial court for the trial court to instruct the jury on this new law of informed consent. Did that, fine. But the jury found that Jerry was unable to establish all of the elements of his claim of informed consent. Maybe they didn't agree that there was a duty to disclose a 1% risk. Maybe that's not something a reasonable patient would find important. Maybe they didn't agree on causation, right? We talked about all this in the prior weeks. An informed consent cause of action has a lot of hurdles for a plaintiff, and it's difficult to navigate all those hurdles, right? And we saw that there In the obituary in the New York Times, despite losing the lawsuit, medical malpractice lawsuit, nevertheless, and as a result of the lawsuit, Jerry, of course, had to be in a wheelchair, be bedbound, and have a lifetime of urinary incontinence. Nevertheless, he was reported in the story to be comforted to know that his lawsuit and his suffering had not been in vain. So while he lost his lawsuit, he thinks, "Oh, I helped make good law, which helps others." Well, what I want to say here, and this is basically the theme of this video, is not so fast, Jerry. Maybe your lawsuit really was in vain, or almost in vain. It's probably had a much smaller impact than he was led to believe, or that many people claim that the lawsuit has had. So Canterbury, of course, at least the appellate opinion, which is the contribution that Jerry thinks that he made to the development of informed consent jurisprudence or patient rights jurisprudence in 1972, 45 years ago. Let's fast forward, right, to today, 45 years later. Where are we? How far have we come? Not too far. Patients often don't know what they're getting, just like Jerry didn't know. In fact, we could say it even stronger. There's definitely enough mathematical evidence to say confidently that patients usually don't know what they're getting. We have terrible outcomes when we look at how informed consent is working. Most patients are seriously misinformed or underinformed or uninformed. Let me just give you 6 examples, and I could give you 60 or 600, but let's just go with 6. First example, right, and this is just this is a surgical study. About 1,000 preoperative patients are in the preoperative clinic after signing informed consent. Okay, so they talked to the clinicians, signed the informed consent document, and now they're in the clinic. 46% of them had serious deficits or major deficits in not knowing the procedure being performed or the risks and or benefits of that procedure. Right? Really, you'd think if you're about to get a procedure and you have just signed informed consent document related to that procedure, you would be able to basically understand key aspects of the procedure. Second example. This was another surgical study, but this was about anesthesia. Specifically, the patients were informed of 4 risks: death, pneumonia, heart attack, and stroke. 4 major risks. There's also a separate part of the study about minor risks, but let's just stick with the major risks. These 4 major risks, okay, they come back a week or 10 days later. On the day of the scheduled surgery, right, only 63% of them could recall any of those 4 major risks that were discussed a week earlier. Third example. Only 5 in 100 patients understood key aspects of their cancer diagnosis. Patients getting palliative chemotherapy. It's palliative only, not curative, but many patients think that it's curative, right? So they misunderstand key aspects of their diagnosis and their treatment. Fourth, only 10 in 100 patients could answer basic questions about their spine surgery. Fifth, Only 12 in 100 patients understood cardiac catheterization. Right. This, and again, these are patients who are getting this or just got this. Six. Right. Only 3 in 100 patients understood basic nature, basic elements about basically stents or PCI interventions. If you just look at these studies and others that have just been published in the past few weeks or months, right, we're talking about a failure rate of greater than 90%. This is a big problem. And you'd wonder, how is this possible? Right? How could it be this bad? How could the vast majority, if not virtually 100% of patients getting a procedure, don't understand basic, key, essential aspects of that procedure? Right? We know already for 40 years there's been a legal duty to inform patients of that very stuff. Right? Thanks, Jerry, for that. Well, at one level, some of them are just getting perhaps the wrong information, right? That happens. Perhaps their clinicians aren't up to date, right? So maybe sometimes the information patients are getting is incomplete. Maybe that's due to the limited amount of time or the limited ability of the clinician at that time. Maybe it's inaccurate. Maybe it's outdated. But that is just focused on the what. That maybe the information that they were given itself wasn't up to date, accurate, and complete. But probably the bigger problem is not the what patients are getting, but instead, even if it is complete, accurate, instead the bigger problem is how, not what the patients are being told, but how they're being told. In other words, the information may be accurate, but it's not meaningfully conveyed. It's not understood by the patients to whom it's given. There's a great book by Alan Alda, the actor, just about this, that physicians and other people in science broadly conceived are not good at relating and communicating information. But I'd like to analogize this before I support this thesis by saying at some level it's kind of like a Miranda warning, right? We tell people you have the right to remain silent, you have the right to an attorney. And the idea is not to really inform the patient, the suspect, the arrestee of their rights. It's to get the warning out so we can say, yes, we did give them their Miranda rights. The police don't really care. The district attorney doesn't really care if they understood them. The goal is to make sure that, yes, they were given. And so another way to think about it would be, look, we need to put these signs up, right? We need to put up a stop sign. We need to put up a wiggly, curvy road sign. Because the highway code requires us to put up that sign. And so we do, right? And let's just say we're the Department of Transportation. I mean, we don't really care if people see the sign or not, because we're just focused on our duties to make sure that sign is there. The sign is put up, great. Sign has been posted. Can't people see the sign? Who the hell cares? So the problem is that because the focus is on making sure the information is conveyed and not making sure that the information is understood, we have vast numbers of uninformed patients. And consequently, a deluge of unwanted medical treatment of type 3, if you go back to the prior video. So we can look at this in terms of outcomes by looking at post procedure interviews, and so we can look at it as a process problem, which is what's the problem? Well, if you've ever been out to dinner, right, you remember that the waiter comes over and tells you the specials. It's hard to remember or even understand what he's saying, but it's definitely hard to remember a few minutes later after the waiter left what those specials were. So I'll just leave that to your imagination. We won't unpack that. So the problem often is that the waiter comes over and says, we have a sea bass and it's this, and we have, a vegetarian dish and it's this. It's just too much information. It's delivered too fast and it's kind of too complex because he's telling you the dishes and the sauces and the sides for all these, 4 or 5 different specials. So it's kind of hard to absorb and remember when it's time to order. Well, the same sort of thing happens in medicine, unfortunately. In 1972, right, we know that that's the year that Canterbury was decided, and we've read Canterbury. What we didn't read in this course was another case, also decided in 1972, on the other side of the country by the California Supreme Court. And in that case, the one of the opinions was written by Justice Mosk, and Justice Mosk, in articulating the new doctrine of informed consent, warned that when clinicians fulfill this duty of informed consent, they should not fulfill it through lengthy polysyllabic discourse. Not a great way to accomplish this. But fast forward 45 years later, 2017, how do clinicians normally communicate with patients about the risks, benefits, and alternatives to treatment? Still through lengthy polysyllabic discourse. Nothing's changed, right? This is me in 1972, right? I've changed a lot since this picture was taken. Unfortunately, informed consent has not. It's sort of been stalled for 45 years. And that shouldn't really be surprising because of the following. Informed consent law wasn't even designed to deal with this problem. It was really designed and set up as a one-way duty, right? It's a duty of the physician to give information to the patient, right? The breach element, right? When we look at the breach element, one of the 4 elements of the tort, we're looking at, was the information conveyed? And if it was, then there's no breach, right? And what we're not looking at when we're assessing whether or not there was breach or not is whether or not the information was conveyed in a meaningful way. We're only really focused on whether it was conveyed at all. So it's sort of just like a dump, right? The physician just shows up with a dump truck full of risks and benefits and alternatives and just says, here you go. And then the question is, from a legal perspective, analyzing an informed consent claim is, did you show up with your dump truck and dump that stuff all out? You're like, yes, I did. Their duty was discharged. Which is unfortunate, of course, because now the patient just has a big giant pile of dirt. Sometimes this problem is described as the following, which is informed consent is not something that's done with patients. Ethically, it should be. It should be done with patients, and many times it is. I'm speaking generally, of course, but instead, the problem is that instead of being done with patients, informed consent is often done to patients. And sometimes the problem is that we use terminology like this, which is consent the patient, which means get the patient's authorization. We don't care really or genuinely about whether the patient's consent is truly informed, but we do want the patient's consent. So we've discharged our duty by telling you about all these risks, benefits, and alternatives. And we also got your consent. So we have two things: no breach, and we have consent. But there's no element in the doctrine of informed consent that really forces an inquiry into the patient's understanding or comprehension. So we're not really eliciting a lot from the patient in terms of, do you understand what I've told you? Unfortunately, informed consent works too much like a lot of other things in the world in terms of consumer disclosures, right? It's enough in many, many areas of commercial transactions that the disclosure is made in fine print, right? It's on the back, or on the inside of the container, in tiny little, 6-point font, right? For some reason, the FTC and the state attorney generals deem this to be sufficient to inform consumers about limitations on their rights. But unfortunately, this is also pretty much the way it works in medicine, which it's enough that that things are disclosed, even if the manner in which they're disclosed isn't really designed to actually inform anybody. If you think back to your 1L contracts class, you may remember the mailbox rule, right? Which is, it's enough to accept an offer by putting the acceptance into the mailbox, right? The acceptance of the offer, and therefore now you have a contract because you have offer and you have acceptance, is effective upon mailing, and not, you don't need to wait until the offeror receives the acceptance. Well, this is, I think, an apt analogy for informed consent, which is, it's apparently sufficient for doctors, to just put the letter into the mail, just like the person who has received a contract offer, which is, that's sufficient to discharge your duty of informed consent. It doesn't matter whether or not the patient actually receives this information in any meaningful way. It's enough. You've discharged your duty just by. So the analogy is putting the letter into the mail.